The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. Welcome to our October 28th Safe and Calm webinar. This is Deanna Mitchell from Leading Age Michigan. And we have an announcement this morning before we get started. We will not be convening a webinar next Wednesday, November 4th. We will be meeting this Friday on October 30th and the following Friday, November 6th, but we will not be meeting on Wednesday next week. But please do check your listservs for any announcements that might come in during that time. So for today, we're going to be using our routine agenda format. We're going to start with Dalton, who has a brief advocacy update. And we're going to touch on the Michigan caseload situation with a focus on the county risk levels. We do know that the number of cases has gone up exponentially in the last couple weeks. And of course, then we will end with our updates on guidance and any additional resources. So at this point, we will turn the presentation over to Dalton, our Director for Public Policy.
Good morning, everyone. The legislature is currently out until after the election, so there's not a lot of new material here, but we thought it would be important that we cover the upcoming due dates and grant applications that need to be completed or should be completed if you want to receive additional funds. And those are COVID support funds of various kinds. And so I put this important date slide first, which you've seen before, which was updated yesterday because of a extension of a due date. But I just wanted to cover this in some detail, and then we'll cover the upcoming applications or processes that will be completed and the due dates that are coming up recently, those on Halloween and some of those on the 6th, so that you can have full knowledge and see if these reimbursement processes apply to you. So firstly, on Halloween, the deadline for the nursing facility infection prevention and control enhancement grants come. We'll talk about this in some detail later, but these are CARES Act funds for you to make infrastructure improvements in your buildings, and you can be reimbursed for all of or part of the cost for those improvements. And we'll talk about this in some more detail later. We can give you some examples. The next deadline on Halloween is the deadline for MDHHS to distribute the SNF PPE reimbursement payments. There's been some confusion around this because there's been a couple of reimbursement PPE reimbursement programs that the state has run. If you remember, the first one had an application process where you received funds based upon provider type. This one does not have an application process and is actually SNFs are the only provider type that are eligible. What they're doing in this one is they're going to be taking the entire bed pool, and they allocated $20 million for this, and dividing that $20 million by the number of licensed beds in SNFs and giving you that amount and distributing that amount of monies to the SNFs in the state. We'll cover that in a little bit more detail later as well. Phase 3 of the Provider Relief Fund applications are due on the 6th. I do have some more information on that later. And the deadline for the COVID-19 vaccine distribution program has been extended to November 6th. So if you have not signed up to or chosen your pharmacy partner for the COVID-19 vaccine distribution program, you have a little more time to make that decision. The 15th is the deadline for the departments to post a public plan regarding care and recovery centers and distinct units. We haven't seen it so far, so we're just kind of waiting on this to get final word to see how this program will roll out. This is a response to the bill that was passed last week, or signed last week, passed 2 weeks ago, that created the CERCs and the distinct unit program and put in place some of those transfer rules. The department does have to issue guidance on that. So we're waiting for some of that. The 1st December is the deadline for submitting a CMP application for visitation aid or in-person visitation aids. So this is the clear plastic dividers, the tents. You can be reimbursed for some of that. Since they are CMP funds, this does only apply to SNFs, but you can be reimbursed for some of those purchases you've made to facilitate in-person visitation. And this grant program is the way you get reimbursed for those. The end of December, this is the end of that second reimbursement period for direct care worker wage pass-through payments. This is that $2 an hour hazard pay premium program that nurses and CNAs are receiving. This ends currently at the end of December or the end of this year. Also at the end of December is the deadline for the purchase or installation of equipment paid for by the infection prevention grants. These are the grants that the due date is October 31st, the ones we'll be talking about after this slide, I believe. And also in early February of next year, this is the deadline for SNFs to submit the the expenditure documentation for those same grants to MDHHS. That is part of the process, but you do need to submit those funds by the 1st of February. So I guess we're gonna start with the SNF PPE reimbursement grants. I forgot the order of my slides quickly. The department must distribute these funds by October 31st, and there is no application process. As I said, they are deciding the amount you will be reimbursed on a per licensed SNF bed basis. They allocated $20 million to the program. I found a number that said there was roughly 47,014 licensed SNF beds in the state. I don't know if that number is the most accurate or current number, but it's going to be close. And so thus you can expect to receive roughly $425.40 per licensed SNF bed. That is a rough estimate, so it'll be somewhere around there. And these payments are subject to audit, so please keep documentation that you've received these payments. I did put the questions email right there for the program. So if you don't receive something by the 31st, please feel free to reach out to us as always, but there's also a link they want you to contact directly at the state as a provider. So I put that there too. Moving on to the Facility Infection Prevention and Control Enhancement Grants. The purpose of these grants is to support permanent improvements to facilities' equipment to achieve more effective infection prevention and control. And as I said, these funds can pay for a portion of or all of the costs for infection control equipment. Only Medicaid certified nursing facilities are eligible, and the deadline is the 31st. So you do have 3 days left to apply for these if you're interested. This link takes you to the homepage for this program, and it also takes you to the application. So click that link and it's kind of all there in one thing. Now moving forward, we'll talk a little bit more about, on the next slide if you don't mind, what exactly is available. These funds are available based upon the poverty rate of your area. So if you're in a high poverty area, you can receive up to $22,000. If you're in a not in a high poverty area, you can receive up to $18,500. The application does list out these areas by county. So it actually lists it by facility, excuse me. So you can check to see if your facility is in one of those high poverty areas directly on that application, which is that link on the last slide. There's the actual grant process right there, kind of spelled out neatly for you. I won't cover that right now, but if you do have just wondering how it works, you can read that briefly on your own time since we already covered it. Here are some examples for what these expenditures can be. So an energy recovery unit, portable UVC unit, HEPA filters, HVAC retrofits, upgrading exhaust fans, physical plant enhancements for visitation rooms, electrostatic foggers, photocatalytic oxidation units, touchless hand sanitizer dispensers, and touchless forehead temperature scanners. A key thing to note is grant funds may not be used to replenish the infection control supplies used in normal operations. That includes PPE and cleaning supplies. So The example I like to use for these, as I'm sure you've heard on these calls, is that you can purchase the hand sanitation or hand sanitizer dispenser, but you can't purchase the hand sanitizer. The grants are not limited to these exact things. So if you do think you have something that may meet these, please apply, because they do not have a lot of applications in right now. So there's a lot of money left over, and they will lose that money by December 31st. So please apply if you're interested. I just wanted to also briefly touch on provider relief funds. We just touched on this last week, so I'm sure you remember some of this, but was an additional $20 billion added to the program federally. The applications for this program are due November 6th. You can see the application link down below, and there is the eligibility criteria right there. I won't run over it again, but essentially, assisted living facilities, Medicare providers, Medicaid providers, and behavioral health providers are all eligible. And then there's some criteria depending on what you have already received or if you have already applied for these payments.
All right. Thank you very much for that, Dalton. Before we get into any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners during our annual conference at our Solutions Expo. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. As of right now, it does not look like we have any questions, so we can go ahead and move on to the next section.
Okay, thank you, Blake and Dalton. We're going to take a look at our caseload numbers and the status of Michigan overall as we move into our 8th month of pandemic response. We know it's been hard on members throughout the course of the epidemic, but in particular, it's been hard this past week. We've seen increases in outbreaks and related staffing issues in several areas across the state. And we seem to be in the middle of a second wave or maybe a third wave, depending on how you look at it. So we're going to start with our standard graphic that depicts the movement in daily caseload over time. If you remember, I updated this from a 60-day graphic of the 7-day average daily caseload a few weeks ago, so that we could better compare current caseload to the early peak period in April. And you can see here that the numbers have grown beyond the highest daily caseload numbers that we reached back in the spring. So this is a serious concern, as we know that local community transmission is one of the biggest factors in long-term care facility outbreaks. Excuse me. The 7-day rolling average of deaths is also rising, but obviously at a far more controlled rate than earlier, but we'll be watching this closely as well. So here is the MySafe Start Map data, which we accessed on Monday, and it includes data through last Friday, the 23rd. I want to be clear that this is not the map that you look at to determine your county risk level for visitation. This map information is basically on a regional level only, although you can determine a county positivity rate and a caseload rate, but they are not the only factors that go into your county risk level determination. You should only be looking at that list, which was attached to the visitation guidance, even though that link says MySafe Start Map, it is not a link to the map. So you can see from this slide that test positivity is rising significantly from 4.7% last week to 5.6% this week, and that new cases per million have markedly risen from 112 per million to 152 per million across the state. So one of the differences in the spread with this current wave is that the cases are pretty much spread out across the state, unlike the spring when they were clustered in certain specific areas, mostly southeast Michigan. This is the data from the MDHHS coronavirus website, and it identifies the cumulative number of confirmed cases for both nursing home staff and residents. And obviously, the cumulative cases are always going to rise. We do want to note that new legislation has recently been signed by the governor that would require the department to actually post daily caseload numbers so that people could track changes in caseload over time. You'll note also that long-term care facilities still lead as the site for most outbreaks in Michigan, although K through 12 schools are following at a close second. Most of the new nursing home outbreaks occurred on the eastern side of the state in the Saginaw region, which includes the Thumb, and in the northern Detroit suburbs. But Detroit proper caseload has been pretty stable recently. There's been a lot of concern recently, over the past couple of weeks actually, about hospital capacity. Apparently hospitalizations for COVID have increased by 80% over the past month, and hospital facilities have seen an increase of more than 1,000 persons hospitalized in just the past 10 days. Hospitals themselves are concerned that we do not have a lot of capacity. Right now we're at about 76% of beds currently filled. And we're also hearing from several members that the hubs are full. And that is going to be a dilemma as this wave continues to hit the communities. There are a limited number of hubs right now as the state works to transition to care and recovery centers. And we've asked the department to comment on alternatives in the interim, but they have yet to respond. So we're going to move on now to our routine discussion of updates and guidance. We want to take just a few minutes this morning to talk about the visitation guidance that went out about 2 weeks ago. We did submit our question list last Friday, and we've yet to hear back from MDHHS. But we do know that there's a lot of concern right now at the department because of the recent peaks in caseload. And several local health departments have already determined that it's too risky to open indoor visitation right now. But you need to look at your overall county situation to make those decisions. The county risk level list as of yesterday was updated as of Monday. I haven't looked at it yet today to see if it was updated for yesterday. And you can access the current list from the visitation guidance that was distributed, or you can use the link that I have here to access it directly. Remember that this list is the only official way to know what your county risk level is. We took a look at some of the data in that list, and it was a bit concerning. Over half of the Michigan counties are at E levels, which is the highest level of concern. And the regions with the highest number of counties at the E level were Grand Rapids, the Upper Peninsula, and the Lansing areas. And also just a note that on Monday, and this is particularly related to visitation, but other things as well, the department rescinded 7 previous MDHH orders. Mostly they were related to some defunct rules that had come out of the governor's executive orders, which are now no longer in effect, but also to update the current visitation orders too. So they have rescinded all of the old visitation guidance as well, and now they're relying just on the most recent one that was sent out about indoor visitation. Another update from MIOSHA. They recently issued updated guidance for employers, for all employers. And this guidance is meant to work to provide a safe work environment during the pandemic. And we know that this is partly, at least, related to the fact that the governor cannot issue pandemic-related orders at this point. And they're doing a lot of that work through individual department guidance. So when we reviewed this, we identified that there's little in these provisions that current CDC and MDHHS guidance doesn't already cover. However, one of the most important pieces that MIOSHA does have the ability to cite and fine employers, so that these requirements may have a bit more teeth than those coming out of MDHHS, for example. One of the requirements is that you must categorize your job tasks based on the CDC categories for risk, and nursing home and long-term care workers are all considered to be at high risk. But the rest of it is pretty much standard in terms of what we're already doing. You have to screen, of course. You have to apply all the safety precautions. And note that the link to the rule, if you want to read it, is at the bottom of this page. The MIOSHA rule does also kind of cement the PPE requirements for persons who are caring for COVID positive persons, with a reference to the CDC recommendations. And there's a real expectation that N95 masks be worn for COVID care whenever possible. And if you're not using N95 masks, you really need to be documenting clearly your attempts to obtain them, and do that on an ongoing basis. You already have to do that for surveyors and the department as well. But remember that these MIOSHA rules hold real teeth. Over time and even recently, we have gotten a lot of questions, and there's been a lot of discussion about the use of N95 masks. Some persons can't be fitted at all for some reason. With all of the products out there that you are having to put together, whenever you change a brand, you would have to refit people. There's questions about who needs to do the fitting, etc. So this has been, a problematic area all along. So we did reach out to the survey agency to get their official take on these issues. Since we did hear last week from a member that surveyors were not citing for lack of fit testing. So while N95 should be used for all COVID care whenever possible, in other words, if you have N95 masks in your building and you have COVID positive residents, you really need to be using those N95 masks as long as they're available for COVID positive and persons under suspicion, observation, etc. But surgical masks can be substituted if you do not have the N95s available, and they also can be substituted if you have not had the ability to have everybody fit tested. That's what we heard unofficially from the department this week. We would prefer it be written in guidance, and they did say that they will try to put that in an update to the surveyor guidance that they're already planning. So I think it was yesterday, maybe Monday or yesterday, we heard from the department that they do plan to update that surveyor guidance that came out about how to cohort and PPE requirements. And hopefully they will include some official information about this fit testing as well. A brief update on the HHS Pharmacy Partnership Program. I have not updated this slide apparently to the new November 6th date. You now have till November 6th to opt in. Remember that this program is designed to administer vaccines to long-term care and congregate living residents when the vaccines become available. So this program is actually dependent on a few things. Number one, the FDA still has to approve the vaccine. And secondly, they also have to prioritize officially long-term care residents in the first tier of people who are meant to get the vaccine. They anticipate that both of those things will happen as soon as the vaccine has really been finalized. But it's still are steps that have to occur before these vaccines are going to be distributed. So Walgreens and CVS, or Omnicare, are poised pretty much to provide 3 on-site visits with each facility to provide these vaccines. And again, you have till November 6th to opt in and identify your preferred provider. So Leading Age has been working with HHS to clarify some of the questions and issues in this pharmacy vaccine program, especially some clarification over some of the shared community settings that are included, such as independent living. Whenever independent living is included, we have a problem with identifying who exactly they mean by that. And there's some discussion about whether or not affordable housing communities might be included. So HHS is working with Leading Age to develop a better definition for both of those entities and how they would be included in the distribution. So originally, certified nursing homes were told to register using the NHSN link, and other facility types were told to use the REDCap online survey. However, all can now register using NHSN if needed. There's a drop-down box now that identifies the type of provider that you might be. But if you're not a nursing home, you can still continue to provide information via the REDCap survey, and that link is listed here. So HHS is planning to follow the individual state definitions for assisted living, and that could be an issue here in Michigan because we don't really have a definition. But we anticipate that both unlicensed and licensed assisted living settings can sign up for this vaccine program. Another note that we should pay attention to is about health workers, healthcare workers. They're a priority for the vaccine, but they're not really intended to be a primary part of this program. Healthcare workers are expected to be vaccinated through a state program, but they included in the Q&A from Leading Age that the pharmacy partnership will vaccinate some healthcare workers who might need it. Another consideration is for older residents living in their own homes. They're also considered a priority, but not as high, of course, as those in congregate settings. It's expected that local health departments will be holding clinics for community-based healthcare workers as well. So some final notes about the pharmacy program. It's expected that pharmacies will bill insurance, but there is intended to be no out-of-pocket costs for residents or staff. So if there is no insurance to be billed, I think the feds plan to pick up the cost for that. The overall program is optional. In other words, as a facility, you do not have to apply for this program through CVS and Walgreens. But if a facility decides to use a local pharmacy for vaccine distribution, that pharmacy must be approved and enrolled with each state health department. So if you're not planning on using Walgreens or CVS, you're going to have to work through that process. So HHS is actually planning on being able to distribute these vaccines within the 24 or 48 hours of FDA approval. And again, please, it's November 6th, it's not October 30. Please make sure that you register with some sort of pharmacy preference by that date. And the other thing is that if there is a 2-dose vaccine system, which sometimes there is, HHS plans to track the administration of the vaccines pretty closely so that there would be a follow-up for persons who might be discharged from your facility prior to the second dose. Okay, we're going to take a minute and pause for questions.
All right, thank you very much, Deanna. Before we get into any questions, Leading Age Michigan wants to thank our business partners for their continued support during the pandemic, and we encourage you to take a look at the logos on the screen. These are the organizations that continue to support the association and your organizations as well. Without their continued support, the Education Foundation would be unable to be as dynamic and innovative as we are. Therefore, when you are considering a purchase of goods or services, please remember this page of logos and consider making a purchase from one of these fine organizations. Also, before we do get into any questions, I figured I would just repeat Deanna's message from earlier, as we've had attendance almost double since then. We will not be holding a Safe and Calm webinar next Wednesday, November 4th. We will still be holding the Safe and Calm webinar this upcoming Friday, October 30th at 11 a.m., but we will not be holding one next Wednesday, November 4th. All right, so let me pull the questions up. This one is more for Dalton, and it's not really a question, just kind of a comment. Just FYI, we reached out to the state and got the amount of our PPE grant, and that worked out to $439.08 per bed.
That's great. Excellent. Okay, so my number was a little off, but generally in the same ballpark. That's great to know. Thank you.
All right. Could it not be interpreted that we are not having more cases, but are doing a better job of testing? Hospitalizations and deaths are down significantly and should be looked at in addition to the positivity.
Well, the positivity rate, the fact that we're doing more testing is a consideration, but there's no question that the caseload's rising in terms of just overall numbers and percentage of persons who are infected. Hospitalizations are going up. There's no question about that as well. So yes, there is part of the variable is about the number of tests that we do, but overall, the positivity rate's going up, and that will tell you that you're finding more cases, so there's more transmission overall.
Do the KN95 masks work in place of the N95?
You are allowed to use KN95 masks, but only if they're on the FDA approval list. I have sent out that list, or at least a link to it, before. I can do that again if you need.
Okay. And so as long as it's approved, it's good, because I just got a second question about the KN95s as well.
Right.
Okay. With the pharmacy partnership, does this mean the emergency management process of using PODs, point of dispensing distribution, will not be used?
I would assume so. My understanding is that they're going to actually come on site at least 3 times per facility and actually distribute the vaccine. In other words, administer it themselves to residents.
Okay. Someone asked if you could resend that list. I'm assuming they're talking about the masks.
Sure. It's a link to the FDA site, and they will tell you all of the KN95 masks that are approved. KN95 masks are simply those that have been manufactured in China. There's a few of them that do meet FDA approval. There's some that do not. So you need to be careful about that. And my understanding is that surveyors do look at that.
Okay. Is it correct that there are no longer restrictions on visits at independent living facilities? Obviously, we would still use many precautions if we did allow visits.
Yes, that is true. In fact, independent living facilities have been kind of moved out of almost every guidance except for one that I'm aware of in terms of care for a COVID positive person. MDHHS guidance does include independent living requirements if they're actually caring, but we all know independent living environments don't actually provide services. So, but that is the only place that independent living is still included. However, I would refer everyone to the CDC recommendations for independent living and shared congregate residences, because as you said, you know, some precautions still have to be taken.
Okay, another question about independent living. Since the MDHHS includes ILs in the recent orders, if in risk level E, IL would not be allowed indoor visits as well, correct?
No, that's not correct. Independent living is not included in the most recent order at all. They have purposely removed it. It's not just an oversight. We've talked to the department about that. Finally, after months and months and months of telling them that independent living has to be considered in a separate way than other residential care facilities. They've removed it from the guidance, and therefore the positivity rates, everything else, the risk levels, I mean, that you have to look at if you're a nursing home or assisted living, do not apply to independent living. But again, you should be looking at CDC guidance because, you know, you do need to take some safety precautions to limit transmission within your communities.
So the surveyor will treat N95 and KN95 the same, providing they are on the approved list?
That's correct.
Okay. It looks like we have one more here. What is the difference between the CDC guidance for communal living versus independent living? They are two separate documents updated on different dates. Which one should we use?
Well, that's a hard question to answer. I don't think that they differ all that much. If you look at them, I would probably review both. And I would look at some of the definitions, I believe, and this is all just from memory, so forgive me. One of them does actually identify that senior housing is included in it. I don't know if it's the communal living or which one it is. I actually saw 3 separate guidance for this type of facility at one point from the CDC, but I didn't see a whole lot of critical differences. I think there might be a little bit more detail in some of the guidance. I would review them all, see which guidance seems to fit your kind of facility the most. But I would say in general, it is all the basic precautions that you would expect. There's one that talks about your level of risk based on what you're doing. In other words, if you're not disallowing group activities, if you're not ensuring social distancing, etc., your level of risk for transmission in your facility goes up. That's included in one of them. I would look at all of them. I think that if just remembering off the top of my head, I don't see a whole lot of difference in anything that would be significant in terms of what you need to do.
Okay. Is independent living, is independent living going to be included when the vaccine comes out?
Yes, we believe so. And as I said before, that's a question that Leading Age has been working with HHS. What we don't know is what they mean by independent living and whether or not they include affordable housing in that definition. So we expect, we're hoping for more clarity coming down the road. Leading Age is working with them to get a little bit better definition. But at some level, yes, independent living type facilities are intended to be included.
All right. It looks like that was the last question, so we can go ahead and move on.
Okay. So a few CDC updates. The CDC has changed its definition of close contacts to a cumulative total of 15 minutes within a 24-hour period, and not just 15 minutes at a time. And a close contact then would be defined as someone who came within 6 feet of an infected person sometime between 48 hours before the onset of symptoms or 2 days prior to any test collection, positive testing, if the person was asymptomatic. So overall risk, according to the guidance, should be considered in light of some other variables as well, such as how close the person was in proximity, whether or not they were indoors or outdoors, the overall duration of the contact, whether or not the person was symptomatic, because even though asymptomatic persons are certainly contagious, symptomatic persons tend to be even more contagious, and whether or not PPE was in use at the time. So you need to think about your close contacts if they should occur, and also some of these other considerations. The link for this guidance is, as usual, at the bottom of the slide. So the guidance also identifies what should be done when a close contact has been identified. So immediately, one needs to notify everyone that they have been in contact with, test immediately, self-quarantine pending results, And of course, it's expected that health care workers will come into contact with COVID positive persons. So they're not really expected to be specifically tested or quarantined when they come into contact, assuming, of course, that they're all wearing appropriate PPE. The CDC also recently updated its strategies for optimizing glove use. We've heard that there have been glove shortages in some areas. Most of the contingency strategy, the left side of this slide, is unchanged. But they do identify specific ways to extend the use of gloves, and they're listed on the right side of the slide. And so they ensure that if you're extending glove use, that you're sanitizing those gloves between people, that you're always discarding whenever it looks like it's visibly soiled or it's damaged in some ways. And they recommend no more than 4 hours of continued use. If you take your gloves off, you should never put them back on. So there's also in this guidance some specific methods for that hand hygiene of gloved hands for extended use as well. So this was an interesting updated guidance. And of course, as usual, the link is at the bottom. The CDC has also updated its considerations for antigen testing in nursing homes, mostly just to include the requirement that nursing homes now must report point of care testing through NHSN. And also a reminder that if you are doing point of care testing, that the CDC flow chart about when you need to do confirmatory testing is really a good guide that people should be using. We still get messages from some facilities who have some concerns about using antigen tests, and we believe that using the algorithm that the CDC has put out is really a pretty safe way to use these antigen tests. So members should be aware of that. And the link for the updated CDC guidance is here. And also along with the actual guidance that identifies the need to report through NHSN. So I apologize for these huge URLs, but our website has not been working properly, so that we haven't been able to redo them in any way. But the CDC has also put out some additional tools for providers. The first is a document that facilities can share with families to identify how they can support their loved ones during the pandemic, and it's a pretty good tool. So members might want to look at that. There's also new guidance that specifies considerations for home care workers and associated precautions specific to home health. And lastly, there is some new guidance about persons who have recovered from COVID beyond 90 days after the onset of the disease. And if developing symptoms should occur at that time, they should probably be retested. But clinicians might consider consulting with an infection control expert as well about those cases. So a few notes, excuse me, about HFA and AFC reporting. Please remember that you must register if you're a licensed HFA or AFC using the new Qualtrics reporting platform by noon today. You should get a link then to be used to report starting on Wednesday, November 4th, and each Wednesday after that. The link to this full reporting guidance is noted also on the slide. And a reminder, I think we sent out something on the listserv a couple days ago, but we did hear over the weekend from the department that they do plan to require licensed HFAs and AFCs, at least the larger AFCs, to start testing. The amount of caseload that's occurring in the state is pretty phenomenal, and the department is really getting concerned about some of these other residential care facilities and the amount of COVID that's there. So testing and reporting for HFAs and AFCs, obviously the reporting part is starting very soon next week, and we anticipate testing guidance any day. And of course, now the certified nursing homes must report antigen testing results through NHSN, and that's already started. Technically, the implementation date is past us. But CMS is really not going to start citing for lack of reporting until mid-November. And the reason for that is that it takes a while to upgrade your SAM's access to level 3 for NHSN. CMS is supposed to be reaching out to facilities who have yet to gain that level of access. They have told us that about 9,000 nursing homes already have level 3 access. But this whole new requirement has raised some big questions about how this will interact with our EM resource reporting that is now required only weekly. So we reached out to the department. And as of yesterday morning, they had said that they had not decided how to move forward with this. And then yesterday afternoon, they came back and said it looks like the facilities are going to have to report POC testing using the NHSN site after they get level 3 access. And they will have to continue to put information into EM resource as well. So there is some consideration out there that CMS and HHS are looking to streamline this so everyone's using one system, but there is no requirement that the state go to an only NHSN reporting system. So the state's still looking at it overall for it, but at least for the time being, you're going to have to input your information into NHSN for point of care testing and continue to put information into EM resource on a weekly basis as well. Another note is that CMS will only be monitoring this to ensure that positive and negative tests are fully being reported. But CLIA will monitor also to make sure that the full 18 elements that they require are also reported. And I believe that that's all going to be in the NHSN system. So Michigan facilities that have reported no on-site point of care test supplies in their weekly NHSN reporting are now being sent Binax Now tests. Remember that these are the tests that don't require a machine, but they use a simple card. The department sent us a list of facilities that they're sending these to. Remember that at this point that they're just nursing homes, at least in this batch. And we noted that we had about 10 members on the list. So they plan to be distributing more soon, but the priority was to those who do not have point of care testing ability yet on site. Remember that these are just like any other antigen test. These are antigen tests, and they have to be reported the same way. Another thing is that the department has issued an FAQ on the Binax Now testing, and that link is here. So Dalton talked briefly about the provider relief grants. And we want to be sure that everyone is aware that HHS has changed its mind again about how to report for these grants, how to identify your financial needs and support that you qualify to keep your grant funds. And I think I may have spoke a little bit about this in an earlier webinar. These same reporting requirements do not apply to the nursing home infection control grants. However, we're not aware of what the reporting requirements are for the nursing home infection control grants because they haven't been decided and they haven't been issued yet. But these provider relief grants have to do with phase 1, 2, and 3 relief grants. And the link to the updated HHS guidance about that is right here. So HHS decided for these provider relief grants that you could use COVID-related expenses or lost revenue. That's what they decided in the beginning. And then in September, they decided that it all has to do with changes in net operating income. And now they have changed back to year-over-year revenue, but you can't use budgeted revenue. So all of this is pretty complicated, especially considering it keeps changing. And so we have asked John Lonzak from Plant Moran to do a workshop kind of session on this whole topic soon when we schedule our next Finance and Strategy Day, and we hope that'll be in just a few weeks. And for phase 3, for the phase 3 provider relief grants, there is an HHS webinar that's scheduled for November 2 about the application process, and that link to register is right there. Remember that all applications must be submitted by November 6th. The process, if you are not aware of it, is that you have to submit your TIN, and once validated, once that TIN is validated, you'll be able to submit your financial data. But if you have submitted your TIN as that first stage of the application process and you've not heard back from HHS, we suggest that you call their provider support line number, because it seems that this November 6th date is a hard date. So if you don't get all of this straightened out by then, you're not going to be able to apply for these funds. And apparently there's some providers who, for some reason that I personally don't understand, there's some people in some sort of stage of applications that they have to cancel a previous application. And that might be messing up their ability to apply in the system. So that's one of the reasons that if you haven't heard by now and you've already submitted your TIN, you should probably call the support line to make sure that you get things straightened out. Okay, and last but not least, there is a National CMS Nursing Home call today from 4:30 to 5, and the dial-in number is there, and or the webcast link is also there for your use if you desire to join. So, questions?
All right. We have a couple, so I'll just hop right into them. We should not be using POC testing for our weekly mass testing, correct? It seems per the flowchart many would need confirmation by PCR anyhow.
Actually, point of care testing is almost intended for that use by HHS. So your serial weekly testing that you have to do for staff for almost every region in the state, because I don't know anybody who's in a low enough risk level to not have to test weekly right now, should be used for that. POC test should be used for that serial testing. Part of the beauty of the POC test is that you get results immediately, practically immediately within 15 minutes. So that if someone's a positive and you're in a fairly high transmission area, you can pretty much bet that that positive is real and you can act on it immediately rather than waiting 2, 3, 4 days for a PCR test. Now the algorithm will tell you what to do if you're in a low transmission area and you get a positive, or you're in a high transmission area and you'll get a negative. It'll tell you what to do with that. But HHS intends for this to be pretty much the primary source for testing staff on a weekly basis. And especially if you can't get a PCR test within 48 hours, you have to use that POC testing. And pretty much the state is depending on POC testing for your visitation guidance to support indoor visitation. I'm not sure if you were going to do PCR testing, how that could possibly work with testing all the visitors. So they're supporting POC testing for that. So the intention is that, indeed, it's used for serial testing as well as diagnostic testing.
Are members having trouble acquiring antigen test kits?
I can't speak to that specifically. I do know that there were 10 providers on the list. The state gave us about 10. I didn't count them exactly, of our members. who were on the list of people who said they had no point of care test supply. So 10 out of 75, 80 members apparently didn't have any in their last PPE reporting, and they were sent by now testing cards. So I would say that they have them. Now, how hard it is for them to get them, I don't know. I have heard at a national level that testing supplies are getting very, very tight overall. And so I don't know how tight for individual facilities in Michigan, but I anticipate that as if the wave continues to go up, that it's going to be a little bit harder. And we have not talked to the department about this directly recently, but I'm sure it'll come up in one of our next calls.
We had an employee who was symptomatic and positive in early April. She was recently ill a couple weeks ago and again tested positive. They've said reinfection is rare, but it has been over 5 months since the first illness, so it doesn't seem like she would still be shedding virus.
That's correct. It's without knowing more about the virus, they're still learning about it. It's wise to consult an infection specialist in these kinds of cases to be sure that every consideration is being made. But I would say 5 months out, yeah, for sure. If you develop symptoms or you retest positive, you need to be considered as contagious.
Okay. Still struggling with two things related to visitation. One, do we have to test visitors entering in SNF and level E for compassionate care visits? Two, do we have to remove non-medical providers in both AL and SNF in level E?
Off the top of my head, level E, for some reason that I can't explain, the department categorized out compassionate care to end of life, critical care, and hospice. So, prior to that, at least I was lumping all of that group together. So testing is never required for end-of-life care. We have asked the department for a definition of end-of-life care because, are we talking about people who are in extremis only, or are we talking people who, might not be with us for more than a week? Where is that line? If they're going to categorize these people differently, we would like a better definition of that. So testing is never required for end-of-life care, but for some reason, even in E, it's required for the other two compassionate care categories. So we've asked for information about that, but that's my understanding to date. It's only end-of-life care. It doesn't require testing in any level, including E. The second question is about non-medical providers and volunteers and students, I think, and whether or not they
I can. It just
can
said.
you repeat
Yeah.
that part? Yeah.
Do we
Repeat
have
that part.
do we have to remove non-medical providers in both AL and SNF in level E?
According to the guidance, yes. But again, we've raised that issue with the department because our feeling is, especially for students, volunteers, granted, I guess you're not going to have any visitation except for end-of-life care in level E, but it didn't make any sense to us to do that. But the guidance does say yes, you're supposed to do that as of now if you're allowing indoor visits at all. In other words, if you're in an area that the health department hasn't shut everything down.
Okay. Going back to N95, KN95 usage for clarification, are these to be worn whether there is positive or negative cases in the HFA facilities?
According to the MDHHS requirements, is that you pretty much need to wear them for all care provided. I think that the surveyor's guidance for nursing homes is a little bit less restrictive if you wanted to rely on that as an HFA. The recommendation is that you provide care using an N95 mask at this point and a shield as well, and goggles, for any care in a congregate living facility, but especially for people prioritized for direct COVID care, and then suspected and other isolated persons, and then the general population. However, N95 fit testing and availability of N95s has been somewhat difficult. So if I were an HFA, I would look at my population and I would look at the availability of supplies and what you really need to do in terms of fit testing, because you can replace it with a surgical mask. The thing is that the requirements for an HFA are different, but if you were a SNF, you would have to document all of your attempts to get N95 masks. I would have to check to see if that's a requirement for HFAs as well. There is an MDHHS guidance that includes all levels of setting and the PPE use requirements for just about everything. And it's off the MDHHS coronavirus resource page. And I think it's called managing COVID, protecting residents in nursing home facilities. It's called something like that. We've sent it out several times. I can send it out again.
Okay. FYI, for other members with multiple small group AFCs, 12 or less, that are on one site, we have 3 AFC homes licensed for 12 per household, and MDHHS confirmed that we do not have to report, despite the fact that there are shared common areas and food prep facilities.
Okay. That's good.
We have not been able to order the supplies for our POC testing machine.
Okay. It's good to know that. Do make sure that you're reporting that, and perhaps the state can help you get some supplies.
Any update on implementing testing in HFAs?
No, I was told on Sunday actually that they expected a guidance to come out by Tuesday. To my knowledge, it has not come out yet, but we anticipate it any day.
All right. Thank you very much, Deanna. It looks like that was the last question. So right now we would like to thank Deanna, thank Dalton, and give you a quick reminder that if you do have any questions that come up in your head after this webinar has concluded, feel free to shoot an email off to Dalton, Deanna, or Safe and Calm at leadingagemi.org, and we will make sure to get that answered for you. Again, another quick reminder that we will not be holding our Safe and Calm webinar next Wednesday, November 4th. We will be holding it this Friday, October 30th at 11 a.m. Eastern Standard Time, just like normal. But next Wednesday, November 4th, we will not be holding a Safe and Calm call. So at this point, we would like to thank our members and participants. I believe that we were at 105 today that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. I hope everyone has a great rest of their Wednesday. And then other than that, like I said, if you have any questions, feel free to shoot them over, and we will see you guys all on Friday. Thank you.
Take care, everyone.